of the cutoffs from these studies, which is a major drawback because this means that we do not have an optimal cutoff for severe, advanced, and also for liver cirrhosis in these patients. So there are also two meta-analyses that are already published, and this is the first one from 2015 for the utility of transient elastography in alcoholic liver disease. There were 5 prospective and 5 retrospective and 9 prospective cohort studies with around 800 patients. A lot of biases in these studies, and the summary sensitivity for advanced fibrosis for transient elastography with a cutoff value around 9.5 was 92%. And as a conclusion, cutoff value of 12.5 kilopascals may rule out actually liver cirrhosis, but they couldn't reach an optimal cutoff value actually. A more recent meta-analysis has the same problem. You have here the variability of the cutoffs, and they looked only for liver cirrhosis, and the cutoff varied from 11 kilopascals to 25 kilopascals, so a very large broad of values that they have found. And again, the optimal cutoff values that were found for significant in severe fibrosis were in range from 7.8 to 9.6 and from 8 to 17. A lot of discrepancies between the cutoff values in the individual studies and differences in liver fibrosis stages. One of the things that may make this variability of the cutoffs was proposed by Professor Mueller, that said that probably the inflammation that was assessed mainly in these patients by the aminotransferase levels is influencing the cutoff values and also the values that we obtain in these patients. And if the patient stops drinking, actually the liver stiffness is going to decrease and the numbers are going to improve. And we should think in these patients to use cutoff values that are related to the presence of cytolysis or not. And of course, we should recommend resuming alcohol drinking, and we should evaluate the patients afterwards. And here you have the proof in several studies that the cutoff values differed, the results differed if the patient was drinking, still drinking, or if they have stopped drinking. And of course, the numbers increased again if the patient relapsed, actually. And when they compared the patients with alcoholic-related liver disease with patients with HCV, if the patient had normal values of aminotransferases, actually the cutoff values for different grades of fibrosis, significant, severe, or liver cirrhosis were pretty the same. So it's very important to know in these patients when we evaluate them which is the level of the transaminases, so if they are still active drinkers or if they have stopped. And if they are active drinkers, to recommend them to stop drinking and have another evaluation after 1, 2, or 1 weeks or 1 month after stopping drinking. Here it's an algorithm that the authors from Germany proposed regarding the evaluation of the liver stiffness in these patients. They took the cutoff value of his 6 kilopascals to rule in patients for evaluation and rule out patients if the liver stiffness was less than 6 kilopascals. And you have to take into consideration the values of the biological markers. We use ultrasound to rule out some of the problems that can be in the liver, and they propose the cutoff value of 8 kilopascals for severe fibrosis and 12.5 kilopascals for liver cirrhosis. What about, I only talked until now about transient elastography, and you have already found out during this morning that there are several other techniques available. The problem is that these techniques are less studied in patients with alcoholic-related liver disease, and for point shear wave elastography and 2D, you have only a few studies that looked, and again, very variable data regarding the cutoffs. So still, for these, we don't have yet enough data to draw a conclusion. This is the most recent study that compared transient elastography, 2D shear wave elastography, and liver biopsy. So there are patients with biopsy-proof liver fibrosis stage. almost 300 patients, and you have here the accuracy for severe fibrosis, for transient elastography and 2D shear wave elastography, and you see that the results are pretty similar. So probably the studies are going to show that any kind of elastography can be used in these patients, but taking in consideration everything that I have told you about aminotransferases and about the drinking problem of the patient. So I think instead of conclusion, I wanted to brought you the data from the guidelines that transient elastography can be used to exclude liver cirrhosis in patients with alcoholic liver disease. So it's a very important method that can be used and should be used in clinical practice. This conclusion was drawn by both guidelines. And it is also introduced in the guideline of the European Association of the Study of the Liver regarding the evaluation of liver diseases, severity and prognosis that was updated in 2021. And again, you see that in this patient, liver stiffness less than 8 kilopascal by transient elastography can rule out advanced fibrosis. And a liver stiffness more than 12 to 15 kilopascal is recommended to rule in actually advanced fibrosis, but be aware that the markers, biological markers that suggest hepatic inflammation may influence these results, and we should repeat the evaluation if the patient is stopped drinking at least after 1 week after the cessation. So we still need information here. We need large prospective studies with single etiology, so we need focused studies on patients with alcoholic liver disease. We do not have yet the optimal cutoff values for significant fibrosis, severe fibrosis, or liver cirrhosis. And I haven't talked anything about screening. There is a place for this technique for screening of these patients, but remember, it's probably much easier to screen a patient with NAFLD because they have other problems, other medical problems, so they are in the system. They are seeing other doctors, the diabetologists, the nutritionist, so somebody is going to refer this patient, while patients with alcohol-related liver diseases usually are not compliant to medical intervention. They are very difficult to spot. The anamnesis is not very easy, so probably until we are going to have very good data, it will take a while. Thank you very much, and I hope you have questions for me.
And I start with the question. I shown that there was 80 paper about NAFLD patient and only 5, I believe in outpatient. Why?
In transient elastography, there are not 5. I think there are 10, but there are 5 with other techniques. I think this is the major problem. Nobody wants these patients. Because they are difficult, they are not compliant, it's very difficult to bring them to the doctor, it's very difficult to follow them up. If they come first, let's say, and we tell them that there is a problem, unless they understand the problem and they stop drinking, and then probably they are going to be compliant to follow up, all the others are going to be lost in the follow-up, and we cannot have enough data because of this. I think this is the major problem.
A second question for people here. We have a lot of patients with risk of NAFLD, patient, obese, diabetic, and they drink. How you call this patient?
BASH.
But we don't use this.
Yes,
we don't use this term, and I believe it's a mistake.
Yes, and I think it's one of the problems that we do not put the correct category. So if we do not use the same criteria and as anamnesis, for example, we need to do the test to find out if the patient is drinking or not, because usually nobody is going to confess. And usually nobody knows exactly what means harmful alcohol intake. So for general public, this is not something that is known. And I think here it's our role, but it's also a difficult role, because to make anamnesis, a correct anamnesis,
but
and to
how
ask,
you call finally in practice?
What?
This patient with both metabolic and alcohol.
Both alcoholic and metabolic.
Okay, but in the literature is not this term. I propose you muffled. It's a correct one because you have metabolic factor and the alcohol is not excluded there. Then probably from clinical point of view for practice, I use muffled in such patients.
But also in those patients, if we do not assess correctly the alcohol intake, we are not going to know which is the major problem.
Sure, sure.
Metabolic one or the alcohol.
Yeah. In this patient, from the data you have shown, we can very nicely see that the inflammation is playing a very important role in the value of liver stiffness, because you showed a study where patients without inflammation, they had the same cutoff value of patients with the chronic hepatitis C or non-alcoholic fatty liver disease. So it seems that rather than the etiology of liver disease, what affects mostly the cutoff is the interplay between fibrosis and inflammation.
Yes, I think this disease is actually the best example to prove this, because it's very easy, not very easy, but if you have a patient that you evaluate at the baseline and they stop drinking and you evaluate them afterwards again and you see it's proven that the numbers, the liver stiffness is decreasing very well afterwards. It's also something that is important for the patient, that he could understand easier, I think, the importance of stopping drinking.
Yeah, and this very quick. This
yes,
decrease
it's evident very quickly.
Yeah.
Yes, yes, Ivica.
Yes, I have one comment, and thank you very much for your presentation, which was great. And I have one comment regarding the liver biopsy. I would like to add to this discussion about the liver biopsy, not only in alcoholic, but also in non-alcoholic fatty liver disease. Because nowadays, given the high prevalence of both conditions, I totally agree with Professor Sporea that there is, we should perform more and more elastography and less biopsies for screening. However, given the high number of these patients, there will be a certain percentage of patients whose elastography results will be above 10 kilopascals. So what to do with these patients? Because we know that all elastography methods tends to overestimate the stage of fibrosis in the higher ranges of elasticity. So if we have patients with liver stiffness more than 10 or 15 kilopascals, if these patients has fatty liver, we are not always 100% sure that the patient is not also drinking, and therefore we cannot rule out the presence of inflammation in the liver. In my practice, for these patients, I perform liver biopsy because I want to be sure whether these patients are really in a stage of advanced fibrosis or cirrhosis or not, because if they are, then we should apply screening rules and screening guidelines in terms of screening for hepatocellular carcinoma and varices. And if they are not in the advanced fibrosis, then we can discard these patients from this very tight follow-up. Could you comment on this?
I totally agree with you. The only problem that we have, and you are happy if you can biopsy them, because for us, the compliance to biopsy is worse than the compliance to biopsy of patients with NAFLD, for those with ILD. But I agree with you, we should biopsy them. But
okay, Alina, thank you very much for your presentation, very interesting one. And now it's my pleasure, we change a little the program. It's my pleasure to invite Ivica Gurgevic from Zagreb, Croatia, to present elastography for portal hypertension. Ivica is the head of Department of Gastro in Zagreb Hospital, and he's very much involved in non-invasive modality of evaluation of the liver and mainly of portal hypertension.
Okay, thank you very much for introduction. It's my great honor to be here, and I thank the organizing committee for invitation, and I would like to congratulate all the organizing committee and Professor Sporea for this great meeting, and it's my Great pleasure to say that we share very long friendship and collaboration, and hope to go on with this collaboration in the future. So the topic of my discussion is ultrasound elastography for portal hypertension, and this is my talk outline. I will mainly focus on the performance of liver and spleen stiffness for predicting the presence of clinically significant portal hypertension and esophageal varices, and also touch upon briefly about the possibility of these two methods to predict the hemodynamic response to non-selective beta blockers. So talking about diagnosing portal hypertension, it is important to understand that gold standard methods are invasive. If we want to numerically quantify the portal hypertension, then we perform measurement of a hepatic venous pressure gradient, and if we want to assess the presence of complication of portal hypertension in form of gastroesophageal varices, then we have to perform endoscopy. And the numerical value of portal hypertension, portal pressure as assessed by HVPG is important because it holds prognostic properties. And if you have HVPG more than 10 millimeters of mercury, then all major complications of portal hypertension start to develop. And below these thresholds, we talk about subclinical portal hypertension. Therefore, it is important to know exactly the number of numerical value of portal pressure. And when we talk about elastography as the method for non-invasive method for assessment of portal hypertension, then we use elastography to measure liver and spleen stiffness, and and we might use different elastographic methods to accomplish this goal. Of course, from transient elastography to point shear wave elastography and two-dimensional shear wave elastography. And one of the first studies that was published in this field demonstrating the correlation between liver stiffness and HVPG was published by Italian group of authors in 2007, in which they demonstrated by using transient elastography very good correlation between liver stiffness and HVPG. But if you look closer to this diagram, then you can clearly see that there are two different parts, two different areas of correlation. So in the first part, in the range of HVPG values of from 3 to 10 or 20 millimeters of mercury, there is a very tight correlation, very strong correlation between liver stiffness and HVPG, because during this first stage of liver portal hypertension, it is mostly influenced by the accumulated fibrotic tissue within the liver, leading to the increased resistance to portal blood flow within the liver. However, in more developed stages of portal hypertension, this association, this correlation almost disappeared, because in this stage it is much more influenced by the circulating hemodynamic factors, I mean by the inflow from the portal vein, and this cannot be captured by measuring liver stiffness. Liver and spleen stiffness have also been demonstrated to be able to differentiate the patients for the presence or the absence of esophageal varices. So this is one of the first study, and I will talk about this a little bit more in further discussion. So now I would like to go through the scientific evidences demonstrating the performance of liver stiffness for assessing the portal hypertension and its complications. And this is one of the first meta-analysis that was published in 2013. And this is a very important meta-analysis because it showed that if you use liver stiffness by transient elastography, it was possible to rule in but not rule out the presence of clinically significant portal hypertension, and vice versa, it was possible to rule out but not to rule in the presence of large esophageal varices. And this meta-analysis and many studies that were published in the meanwhile led to first Baveno guidelines. I mean, this was Baveno 6 guidelines, Baveno 6 consensus in 2015. Which stated that liver stiffness, as assessed by transient elastography, might be used for ruling out the presence, in the presence of clinically significant portal hypertension in patients with liver stiffness higher than 20 to 25 kilopascals, but also might be used to rule out the presence of varices needing treatment if liver stiffness was less than 20 and platelet count was more than 150, and these patients could safely avoid upper GI endoscopy. Again, many studies have been published from that time evaluating these criteria, and which finally resulted in this meta-analysis published in 2019 that included more than 7,000 patients evaluating these Baveno 6 criteria, and the authors demonstrated in this meta-analysis a very good performance of a Baveno 6 criteria with area under the curve of 0.9 with very good sensitivity for ruling out the varices needing treatment. And by applying these criteria to a hypothetical cohort of 1,000 patients with compensated advanced chronic liver disease, it was possible to avoid upper GI endoscopy in 26% of patients with only 0.6% of risk of missing high-risk esophageal varices. There was one issue that has not been addressed in Baveno 6 guidelines, and we finally got the answer to this question in 2021, and that was the issue how to rule out. So Baveno 6 guidelines told us how to rule in clinically significant portal hypertension, but not how to rule it out. And then in 2021, the multicentric study, multinational multicentric study by Pons et al. Was published in American Journal of Gastroenterology, and they calculated the cutoff value of liver stiffness plus platelet counts. So liver stiffness less than 15 kilopascals and platelet counts more than 150 were very good for ruling out the presence of clinically significant portal hypertension with negative predictive value of almost 97%. What is also interesting is that they calculated the liver stiffness cutoff value for ruling in the presence of clinically significant portal hypertension. It was equal or more than 25 kilopascals, and it worked well across all etiologies of chronic liver disease except for obese NASH patients. So in obese NASH patients, the liver stiffness of more than 25 kilopascals was not that frequently associated with the presence of clinically significant portal hypertension. And this was also confirmed in our study from our center where we evaluated these Pons criteria for assessing the presence of clinically significant portal hypertension. And in this diagram here, you can see that for the same level of liver stiffness, if we have obese patient in comparison to non-obese patients, lower platelet count was needed to qualify this patient for the presence of clinically significant portal hypertension, and vice versa. For the same level of platelet count, patient need to have higher liver stiffness if he or she was obese than non-obese to enter the arena of clinically significant portal hypertension. These were data about transient elastography. Now I will move to other ultrasound elastography techniques. This here is the study from Italy using point shear wave elastography point quantification by Philips, and they tested this method for assessing for the presence of varices needing treatment. They included almost 200 patients with hepatitis C, and they used Baveno approach, so a combination of liver stiffness and platelet count, and they calculated the cutoff value for this method of 12 kilopascals. That was the optimal for ruling out varices needing treatment. So combination of liver stiffness less than 12 and platelet count more than 150 had sensitivity of 95% and negative predictive value of 99% to rule out varices needing treatment. And by this combination, it was possible to avoid 38% of endoscopies with only 1% of risk of missing varices needing treatment. As for the 2D shear wave elastography, a meta-analysis of 5 studies with around 300 patients was performed, in which they included 27% of patients with compensated cirrhosis, the other were decompensated or had history of decompensation, and they calculated cutoff values for ruling in and ruling out clinically significant portal hypertension and varices needing treatment, so 14 kilopascals by 2D shear wave elastography by supersonic ultrasonic imaging for ruling out clinically significant portal hypertension and 32 kilopascals for ruling it in. And for varices needing treatment, 14 kilopascals for ruling out and 50 kilopascals for ruling in. However, please note that 76% of patients would remain in the gray zone in between these two values, meaning there would remain unclassified. And this meta-analysis was criticized for the fact that it included only 27% of compensated patients. So majority of patients in this meta-analysis were patients with decompensated cirrhosis. And we know from that patients who are decompensated by definition already have clinically significant portal hypertension. And in fact, we really do not need to measure liver stiffness to know whether these patients do or do not have clinically significant portal hypertension. Now I would like to move and show you some scientific evidences for the use of spleen stiffness measurement for clinically significant portal hypertension in esophageal varices. And there is a meta-analysis published in 2018 that included 9 studies and almost 700 patients. Again, they included both compensated and decompensated patients with mixed etiology of chronic liver disease, and they included studies with different elastographic methods. Nevertheless, correlation of spleen stiffness with different elastographic methods with HVPG was good, with 0.72, and very good performance was observed for diagnosing clinically significant portal hypertension. The area under the curve was 0.9, and for severe portal hypertension 0.87, which was pretty good. However, the authors highlighted the fact that for these higher ranges of portal hypertension, measuring spleen stiffness had a little bit less good specificity, which was below 80%, and they stated in their paper that maybe for assessment of the entire range of the portal hypertension, spleen stiffness might not still be ready to be used in clinical practice. Very similar observation was noticed in this study coming from Korea, in which they assessed liver and spleen stiffness in 99 cirrhotic patients with high grade of portal hypertension. So they had patients with 3 categories of portal hypertension with more than 12, 16, and 20 millimeters of mercury in HVPG, and they showed that the correlation of liver and spleen stiffness was different across these stages of portal hypertension. It was always better for spleen stiffness than for liver stiffness, but again, with the increase in portal pressure, with the increase of portal hypertension, correlation between spleen stiffness and HVPG steadily decreased. As for the use of spleen stiffness for screening of esophageal varices, this is meta-analysis from 2014, showing that spleen stiffness did not have sufficiently good sensitivity or specificity for diagnosing any esophageal varices or large esophageal varices. But then another very important study was published in 2018 coming from Antonio Colecchia group in Italy. They included almost 500 patients with compensated advanced chronic liver disease. And what they suggested, when we have patients with CACLD, then in the first step we should perform, we should apply standard Baveno criteria, so combination of liver stiffness and platelet count. And if patient did not fit into these criteria, then for the second step we should perform spleen stiffness measurement, and they came to the cutoff value of spleen stiffness of below 46 kilopascals, which had a very high negative predictive value of 98%, which could be used for ruling out the presence of large esophageal varices. And by combining this two-step approach, it was possible to avoid upper GI endoscopies in 42% of patients with 3% risk of missing varices needing treatment. And this finally led to Baveno 7 recommendations, according to which the presence of clinically significant portal hypertension can be ruled in patients with liver stiffness of more than 25 kilopascals by transient elastography. It could be ruled out if patient had liver stiffness less than 15 and platelets more than 150, and varices needing treatment could be ruled out if liver stiffness was below 20 and platelets more than 150. What is new here in Baveno is that they also added the values of spleen stiffness that could be used for assessing these patients. So if patients had spleen stiffness less than 21 kilopascals, clinically significant portal hypertension might be ruled